Bismillahirrahmanirrahim. Once again, welcome to my lecture number 38. As we know that we have already discussed about the different type of drugs which connect on the cardiovascular system. So this is so in this lecture we will cover all the course objectives which I have mentioned here. In this lecture we will discuss about the main classes of the drugs that are used for treating the angina pectoris, discuss the nursing responsibility of each class of drugs. We will also discuss the pharmacological management of hypertension and hypertensive crisis, and discuss the nursing responsibility related to antihypertensive drugs, and then we should calculate the drug dosage accurately while administering oral and parenteral medications. Now come toward the main topics. First of all, I would like to define the antihypertensive drugs. Before studying the antihypertensive drugs, I would like to define hypertension. What is hypertension? Hypertension is a persistent rise of blood pressure above the upper limit of the normal level according to the age and sex of an individual is called hypertension. Or in simple words, you can say this is a persistent or prolonged rise of blood pressure above the upper limit of the normal limits. For example, look at here the normal limits of blood pressure. One is systolic pressure, the second one is diastolic pressure. Systolic is also called contraction of heart, which is vary from it may be 100 and 140 mmHg or 120 plus minus 20, and the diastolic is 60 to 90 mmHg. And R 75 plus minus 15. So these are the normal limits of the blood pressure. So if it is in the range of this is in simple word, you can say systolic is 100 to 140 mmHg and diastolic is 60 to 90 mmHg. The causes, the clinical etiology of hypertension. The first one is primary hypertension. So primary hypertension is almost about 90 to 95%, which is also known as essential hypertension. The exact cause of the primary hypertension is unknown or idiopathic. Still its cause is unknown because there are some multiple factors which are involved. If the cause of the disease is unknown, so it means that there are some multiple factors which are involved. I mean that blood pressure, hypertension, it may be due to obesity, it may be due to stress, it may be due to anxiety, it may be due to tension. So there are many more. It may be due to arteriosclerosis. So there are many reasons behind primary hypertension. Secondary hypertension is 5 to 10%, and secondary hypertension, it may be due to renal disease, and it may be due to endocrine disease or Crohn's disease, acromegaly, and 5 chromocytoma. It may be due to rare tumor of the pheochromocytoma is the rare tumor of the adrenal gland tissue. The second one is Cushing disease. So it is also the main cause of secondary hypertension, which is almost about 5 to 10%. So it means that the range, the primary hypertension, the chances of primary hypertension is 90 to 95%. Mean that 90 to 95% that is primary hypertension, especially in the community and the peoples. So most of the patients, 90 to 95% of the patients, they have primary hypertension, and 5 to 10% of the patients, they have secondary hypertension. Secondary hypertension may be due to, as I have mentioned, it may be due to renal disease, due to endocrine disease, due to Cushing disease, and it may be due to vascular causes, maybe renal artery stenosis may be a cause. Stenosis means narrowing of the blood vessels, narrowings. While the coarctation of aorta means narrowing of the aorta, which is the major blood vessel which can distribute blood to all parts of the body. The drugs may be sympathomimetics, NSAID, non-steroidal anti-inflammatory drugs, contraceptive pills, and steroids. These are the risk factors which may lead to hypertension. So the first one is age, the second one is hereditary, anxiety, obesity and lack of exercise, alcohol consumption and salt intake. It means that all factors can lead you toward hypertensions. While the second one is special patient group that may be depend upon on the race, elderly, FD patient who is diabetic, so there may be chances of hypertensions. Whenever there is renal disease, whenever there is stroke, pregnancy, hormone replacement therapy and oral contraceptives. These are the special patient groups. So these are also the leading factor toward hypertension. Okay, so this should now come toward the management of hypertension, how you can manage the hypertension of a person who is hypertension, so how you will control it. So the first one is non-pharmacological approach. So in non-pharmacological approach, we can say the weight reductions in the obese patient, especially we should reduce about 2.5 to 1.5 mm per kg weight loss, restriction to salt intake not more than 6 gram NaCl, dietary consideration, legumes, fresh fruits and vegetables, whole grains and many more. Regular exercise, it is very necessary. So regular exercise, it also come under the category of non-pharmacological therapy. After that, restricted the alcohol intake, smoking cessation to reduce the cardiovascular risk. Now come toward the pharmacological approach. As I was talking about the how we can manage the hypertension, so in first priority I have discussed about the non-pharmacological approach, that how you can reduce it, how you can control, how you can manage the hypertension. So these are the factors which I have explained. So through these parameters you can control you can manage the hypertensions. The second one is pharmacological approach. So in pharmacological approach, and simple you can say in pharmacological, you will use different type of drugs, and with the help of these drugs you can control, you can manage the hypertension. So as we know that there are different type of drugs which are used in the management and the treatment of hypertensions, which are already given here. Look at here. So pharmacologically it is classified into different categories. The first one is diuretics. You know, diuretics, actually these are those drugs which can increase the urine output, which can increase the urine. After giving the diuretic, the urine output increases, and these are the drugs which are used in the treatment of hypertension. So and diuretic can include carbonic anhydrase inhibitors, that is called acetazolamide. So acetazolamide, it belongs to carbonic anhydrase inhibitor. The second one is loop diuretics. So loop diuretics which include the furosemide, ethaclinic acid and mercurials. So these are the drugs, especially all these are drugs come under the category of diuretics. The third one is thiazide diuretics, which include the hydrochlorothiazides. The fourth one is potassium sparing diuretics, which include amiloride, trimetrin and spironolactones, while the fifth one is osmotic diuretics, which include the mannitol. We have discussed all these 5 categories. So these are the main groups, diuretics, and then diuretics contain all these groups, and these are the drugs which belong to this category. So for example, in simple words you can say furosemide or furosemides, which is available in a market by trade name Lasix. So actually it belong to loop diuretics. So in the same cases here, thyroid diuretics, it belong to what? Hydrochlorothiazide, it belong to thiazide diuretics. So amiloride belong to potassium sparing diuretics, and mannitol, it belong to osmotic diuretics. Okay, so the second one is sympatholitics. Sympatholitics actually which include sympatholytics include the central acting drugs, for example methyl, dopa and clonidine. So these are also the drugs which are used in the treatment of hypertension. The second one is beta blockers. So beta blocker include atenolol, propranolol, metoprolols. The third one is alpha blockers. So alpha blockers include prazosin and pentolamine, while the fourth one is adrenergic neuron blocker, that is called guanethidines and reserpine. So all these are the pharmacological approach, and these are drugs which are used in the management of hypertension. So then it depends upon on the condition of the patient. So according to the condition of the patient, you can administer these drugs. The third one is direct vasodilator. You know, direct vasodilator, which can dilate the blood vessels in order to reduce the to minimize or to control the hypertensions. The first one is arteriolar dilators, that is called diazixides, hydralazine, minoxidil, and prazosines. Whenever these drugs are given to the hypertensive patients, so it can directly elevate it, or it can dilate the blood vessels in order to normalize the blood pressure. The second one is vasodilator, that is called non-selective. So the non-selective vasodilator are sodium, you can say nitroprusids and prazosine. So these are the drugs, you know, minoxidil. So this is also a potent vasodilator. So they are also used in the treatment of male pattern baldness and many more conditions. The another one is calcium channel blockers. So calcium channel blocker, it include nifedipine, verapamine, and diltiazem. And the fourth one is angiotensin converting enzyme, that is called AC inhibitors, which include captopril, enalaprils, lisinoprils, and ramiprils. Alpha-methyl dopa, as we know that this drug is available in a market by trade names Ultimate methyl dopa. So alpha-methyl dopa, pharmacologically it is useful in the treatment of mild to moderate severe hypertensions. Alpha-methyl dopa, they're responsible to reduce the blood pressure cheaply by reducing the peripheral vascular resistance, and it can directly inhibit the noradrenaline production or synthesis. As we know that dopa, dihydroxyphenylalanine, so they are converted into dopamine with the help of dopa decarboxylase, which is the name of that enzyme, and that enzyme convert the dopa into dopamine. And then the alpha methyl dopa, they are converted into methyl dopamine, and then again it become converted into alpha methyl noradrenaline. It remain inside the vesicles and release in the same way as noradrenaline. So it means these are the drugs which are used in the management of hypertensions. Whenever the patient conditions you want to normalize it, so after these drugs can be recommended. The mechanism of action or mode of action of alpha-methyl dopa, so it forms the pulse neurotransmitters which are called acetylcholine. So alpha-methyl noradrenalines, which combine with the alpha adrenoceptors which are present in the surface of the lower brain stem. So it can inhibiting the neuron of the nucleus of the tractus, so the trace of the vagus, which is turn decrease the central and peripheral sympathetic activities, and resulting in and decrease the blood pressure. So it means this is the very general mechanism that how the methyl dopa can act in order to normalize the blood pressures. So it can also inhibit the T-carboxylation of the dopa, dihydroxyphenylalanine, and then 5-hydroxytryptamine, and thus it decrease the sympathetic tone. It can also directly reduce the renin activity, which is responsible for the conversion of angiotensin 1 to angiotensin 2, thereby reducing the blood pressures. So as we know that how these methyl dopa, it can also directly reduce the renins. And you know, renin, this is actually the hormone which is released by the kidney, which can elevate the blood pressure. So it can block or reduce the renin productions, the renin activity, which is responsible, and this renin is responsible for the conversion of angiotensin 1 to angiotensin 2. And as we know that angiotensin 2 is vasoconstrictor, so it can block actually the renins, which is responsible for the conversion of angiotensin 1 to angiotensin 2 in order to normalize or reducing the blood pressure. So this is very simple mechanism. You can study all these materials and they are very easy to understand. Okay, so now come to the pharmacokinetic profile of the alpha-methyl dopa. Pharmacokinetics mean absorption of drug, distribution of drug, metabolism of drug, and excretion of drug is called pharmacokinetic, that what embodied with the drug. So the pharmacokinetic profile of alpha-methyl dopa. So this drug is well absorbed from gastrointestinal tract. Its half-life is 1.5 hours. Its antihypertensive effect is 4 to 6 hours, and it is effective twice daily, and its dose is 1 to 2 grams there and divided dose. Methyl dopa, it is used in the treatment of hypertension, mild to moderate to severe hypertension. They are also used in the treatment of hypertensive crisis. They are also used in the treatment of pheochromocytoma, so tumor in the adrenal gland. So they are also used against the tumor which is formed in the adrenal gland, and they are also used in the treatment of malignant carcinoids. These are the ADR, adverse drug reaction of methyl dopa, alpha-methyl dopa. These are the adverse effects which are reported, and you know that these are the unwanted or undesirable effects which is always occur due to overdosings. So adverse effects which are reported by the different literature review, that may be in the form of mental symptoms, sedation, lethargy or sluggishness, vertigo. Electrolytes imbalance may be occur especially due to overuse of alpha-methyl dopa. Thrombocytopenia may be occur, decrease the production of platelets, and the bone marrow. Headache may be occurs. Psychic depression, lactation may be occur, dryness of mouth, edema, postural hypertension, and allergic reaction that come under the category of ADR. So these are the adverse drug reaction which are reported after administration of what? After administration of alpha-methyl dopa, which is used in the treatment of and the management of hypertension, hypertensive crisis. The unique side effect, the flushing of skin may be occur, and there may be chances of failure of ejaculations, depression may be occur, hemolytic anemia, and granulocytopenia, especially decrease the production of granulocytes. So WBC, white blood cells, they are maybe granulocyte, they may be granular or agranular. So actually here in this case means that after administrations or due to after administration of methyl dopa, alpha-methyl dopa, there may be chances of decrease the production of granulocytes. So you become unable to fight against infections, against disease. So hepatic disturbance may be occurs. Now this is another drug which is called Clonidine. So Clonidine it is centrally acting sympatholytic agent, and they can directly act on the alpha-2 adrenoceptor agonist. So sympatholytics mean which can mimic, which can broken down, or which can which can relieve, which can suppress the sympathetic activity, and they can act by decreasing the central sympathetic activity. The simple mode of action or mechanism of action of Clonidine, it combined with the alpha-2 receptor of the lower brain stem, which is in turn it can inhibit the release of noradrenaline from the neuron. So it means actually Clonidine, it can directly combine with alpha-2 receptor of the lower brain stems, and they are responsible to inhibit, to stop the release of noradrenaline from the neuron. So it can decrease the sympathetic activities, which results in decrease the cardiac outputs. So when the cardiac output it become reduced due to decrease in heart rate, so there will be a relaxation of the capacitant vessels, and the blood pressure it become decrease, it become minimized. The pharmacological, look at here the pharmacological action of Clonidine. So Clonidine, as we know that this is alpha-2 adrenoceptor agonist, because it can directly act on the alpha-2 adrenoceptors, and it can increase the activity of sympathetic activity. So in order to decrease the central sympathetic activity, this drug is used. Pharmacological action of clonidines, as we know that clonidines and central nervous system, these clonidine, it suppress the sympathetic outflow, and cardiovascular system, clonidine, it decrease, it cause bradycardia, decrease heart rate, and decrease the cardiac output. As we know that blood pressure is equal to cardiac output multiplied by peripheral resistance of the blood vessels. So the blood vessels, the pharmacological action of clonidine on the blood vessel, it causes reduction in the resistance and relaxation of the capacitance vessels. The clinical uses of clonidine, they are used in the treatment of hypertension. They are also used in the prophylaxis of migraine, and they are also used in the diagnosis of pheochromocytoma whenever there is formation of tumor in the adrenal glands. So adrenal glands, they are responsible to release different type of hormones. It may be in the form of adrenaline, epinephrine, norepinephrine, renins. The adverse effects of clonidine, which are reported by literature, that may produce sedation, dryness of mouth maybe occurs, drowsiness, rebound hypertension may be occur. The pharmacokinetics of clonidine, its bioavailability is 75%. You know better about the bioavailability. 75% is the bioavailability of clonidine. Half-life is 8 to 12 hours. The excretion, the half-life of the, it means that half of the drug is excreted in unchanged form. Normally the dose of the clonidine is 0.2 to 1.2 milligram per day. Sudden withdrawal effects. In case of sudden withdrawals, it can result in life-threatening crisis, and the patient exhibit the nervousness, tachycardia, headache, and sweating if 1 or 2 doses is omitted. So note, sudden withdrawal of this drug must be avoided. Let's suppose if this drug is withdrawn, so there may be chance of multiple complications. If required, should be done gradually. Okay, so now come to our calcium channel blocker. So calcium channel blocker, calcium as the cheap ion required for the cardiac contraction, smooth muscle contraction, propagation of the cardiac impulses. The classification of calcium channel blockers, the first one is dihydropyridine family, which include the nifedipines, nicodipine, and nisoldipines, amlodipines, and esradipines. Another one is miscellaneous group, the max group, which include the verapamil, diltiazem, and peptidyls. The general pharmacokinetics for calcium channel blockers, so it can be orally administered to the patients. They are highly protein bound drug, and its hepatic phosphatic metabolism occurs in the liver, and it can be excreted through kidneys. The mode of action or mechanism of action of calcium channel blockers. So calcium channel blockers bind with the voltage dependent calcium channel, L-type channels, and the depolarized membrane. You know, depolarized membrane action potentials, repolarization, hyperpolarizations. So before this, you will have to study about the action potential, that how the action potential is generated, and then how repolarization and depolarization is occurs. So actually this calcium channel blocker, actually it can block, it can bind with the voltage dependent calcium channel L type, which can depolarize the membrane, and the resultant effects in relaxations. Whenever there is depolarization is occurs, so as a result of relaxation, the smooth muscle will become relaxed, and the negative inotropic effect and chronotropic action in the heart is occur here. In case of repolarization, so there is a contraction of the smooth muscle, while in case of depolarization, when the membrane is depolarization, so the smooth muscles become relaxed, and the negative inotropic and chronotropic action occur on the heart. The pharmacological actions of the calcium channel blockers. So in cardiovascular system, it can dilate the main coronary vessel, which can improve the myocardial perfusions. So it can also cause negative chronotropic effect in cardiac slowings. It means that the heart rate becomes slow, and atrioventricular atrioventricular blockage maybe occurs. And negative anotropic effect means decrease the force of contraction of the heart muscles, especially the myocardium's contractility become decreased. The fourth one is vasodilatations can be occur. It can decrease the total peripheral resistance of the smooth muscles. And smooth muscles, the calcium channel blocker, so it produces a vascular smooth muscle generalized relaxation. It can cause the coronary vasodilatation, especially in anti-anginal action. So, and third case, visceral smooth muscle relaxation of the biliary tract maybe occurs, and as well as the uterus also become relaxed, as well as the bladder is also relaxed. It means that smooth muscle relaxation can be occurs. The clinical uses of calcium channel blockers, they are used in the treatment of angina pectoris, variant angina. They are also used in the treatment of hypertensions, as well as they are also indicated for the cardiac arrhythmias whenever there is abnormal heart beating. So the calcium channel blocker, they are also used in the prevention of ischemic neurological damage due to subarachnoid damage. It is also used in the treatment of Raynaud disease, and as well as migraine and premature labors. Now, what are the condition, and with the calcium channel blocker they are contraindicated. So this point should be noted, that especially whenever a patient who is suffering from heart failures, so calcium channel blocker they are avoided, while especially in bradycardia when the heart rate becomes low, so calcium channel blockers, so they are restricted there. So the second or third degree AV blockage, ventricular blockage, they are also contraindicated. So calcium channel blocker are contraindicated in case of heart failures. They are contraindicated in case of bradycardia. They are contraindicated in second or third degree AV block. They are also contraindicated in sex sinus syndrome, and they cannot be used in Wolff-Parkinson-White syndromes. These are the adverse effects which are reported after administrations of the calcium channel blocker due to vasodilatation. Postural hypertension may be occur, reflex tachycardia may be occurs, and bradycardia, palpitation, headache, flushing, dizziness, ankle edema, and gastrointestinal tract constipation may be occur, nausea, vomiting, and gum hypertrophy may be occurs. ACE inhibitor, which are also called angiotensin converting enzymes inhibitors, so it include captopril, enalapril, lisinopril, and ramiprils. The mechanism of action, so you know that how these ACE inhibitor can do their actions. So angiotensin converting enzymes, it can act by inhibiting the conversion of angiotensin 1 to angiotensin 2. As we know that angiotensin 2, which is a powerful vasoconstrictor, so it can act favorably on the angiotensin sensitive vascular bed of the kidney, brain, and you can say brain, kidney, and as well as especially your whole nervous system is involved, because there is a proper communication between kidney, you can say kidney, heart, and brain. The mode of action or mechanism of action of angiotensin converting enzyme, so it can inhibit or stop the conversion of angiotensin 1 to angiotensin 2. So thus the vasoconstrictive action of the angiotensin 2 is inhibited or diminished. So also the ACE inhibitor cause inactivation of the bradykinin. You know that bradykinin is vasodilator peptides, and this vasodilator peptide, but in the presence of ACE inhibitor, the bradykinin is active and cause the vasodilatation, which turn and decrease the total peripheral resistance, and finally the blood pressure it become minimized, it become controls. These are the pharmacological actions of the ACE inhibitors. So the pharmacological actions, so it may cause vasodilatation, reduction of the TPR, total peripheral resistance. It may reduce the preload and afterload, which we have discussed in physiology, reduction in the secretion of aldosterone or decrease the salt and water retention, and it can also increase in the renal blood flow. As we know that AC inhibitor, they are used in the treatment of hypertension, especially in renovascular hypertension due to excess renins. They are also used in the management of malignant hypertension, and they are also used in the treatment of hypertensive crisis of scleroderma whenever there is hardening of the skin occur, and they are also used especially the clinical uses, especially used in end stage renal disease, as well as they are used in the manage and the treatment of refractory heart failure, as well as ischemic heart disease. These are the adverse effects which are reported by the AC inhibitors, angiotensin converting enzyme. So the first dose is hypertension, dry cough may be occur, angioneurotic edema, hyperkalemia, loss of appetite, and as well as stomatitis may be occur. Stomatitis mean especially inflammations and the oral, especially and the linings of the mucosa, of the oral cavities of mucosa. The abdominal pains may be occur, neutropenia and proteinuria, and blood disorder may be occur. AC inhibitors, angiotensin converting enzymes, especially they are contraindicated in systolic pressure. When it is less than mm systolic pressure is less than mmHg. So it is bilateral renal artery stenosis in second and third trimester of pregnancy. It means that calcium channel blocker, it cannot be used in the second and third trimester of pregnancy, and it cannot be used in case of renal failure. Now, what are angiotensin receptor blockers? Inshallah, I will discuss about the angiotensin receptor blockers in my next lecture. Thank you so much for watching my lecture. So if you have any question regarding my lecture, so you can directly contact me through WhatsApps, which is already available on my YouTube channel. Thank you so much, my dear students and viewers.